I think maybe last December. I'm trying to remember the actual month where we did a webinar on CMS edits, and we were getting into some of these details. And I offered this out, and a lot of people responded and said they would be interested in this topic. This is, and just a little background, when I do education for HFMA, which I've done now for almost 30 years. So yes, so somebody's getting old, but I'm not sure who it is. But I try to stay on the very kind of, I would say, more technical side of the education spectrum here. So as we go through here, there's going to be a few links in the presentation. And what I try to always do is give you some takeaway information where you can go and read up and get some additional information. Over the last many years, CMS and your individual MACs and state groups have all increased their presence on the web, and there's so much more information that's usable on the CMS website and other websites than obviously there was a number of years ago when we were all pouring through paper manuals trying to figure this stuff out, and flow charting DRGs, and I'm not actually making that up. So there's a lot of good information. Again, we're going to go down a kind of specific area today on the ANSI 835, which is your remittance. This is just, obviously we're not doing web, but that's what I look like if anybody has not met me. And for those of you who have not met me, I plan on being at the national meeting this year in Denver. And I think we're going to be there for Centauri. So if you've not met me before, please stop by the booth and say hello. I'd love to meet you guys. And I'm kind of a dual Colorado and Central Texas resident. I go back and forth between the two. They both have great weather, so I enjoy both, but I'm in Texas today just to give you some geography. Let's talk a little bit about the agenda today. And again, drop your questions into chat, and hopefully at the end we will cover all those. And you know, last time we had some great dynamic questions, a great conversation. We're going to talk a little bit about ANSI basics and kind of what composes that data set, and then get into, and again, I may not cover all of this, but you know, it's a good start on this information. But of course, when you start talking about your remittance, the next thing that logically comes up is discussion about denials. And then we'll talk a little bit about some of my experience over the years of how you work denials. And of course, everybody's going to have different experience on this. And of course, at the end of any discussion, you should be able to talk about how you measure your success. But I think the core part of this presentation is going to be on these ANSI basics. And as you know, if you know, we have a lot of different ANSI data sets that were all essentially mandated in the HIPAA process between 2000 and 2003. In 3 different iterations, we had the rollout of HIPAA, and that in those days we called them the transactional data sets. So they can be referred to a lot of different things. But at the end, what they really should be doing is making our life easier. And I say that from somebody who's actually sat down at an IBM SelectWrite and typed out a UB82, which was the predecessor to the UB92, which is the predecessor to UB04, which is now the ANSI 837. And so these are very powerful data sets. They are certainly much better than paper. And I don't know if anyone still get any paper remits. I know that there are a handful of organizations that are statutorily excluded from the requirements for the ANSI 835. So you may be getting some paper, and you may not even know, because there's a number of vendors out there that will convert the paper to the EDI or the ANSI 835 set. But yeah, if you may be getting paper, you may not. I haven't heard from anyone in a few years on this, but generally there's a couple of handful of like state organizations or things that are exempt from this. So we're going to talk a little bit about this data set. And I got a big mug of tea here I'm drinking to keep my voice nice and lubricated. But what the ANSI 835 really is is it's an accounting transaction. It is a balancing to your accounts receivable system, which again is also an accounting system. It's debits and credits. And what this 835 is doing is it's coming back to you with those debits and credits to your accounting system in hopefully an automated fashion so that you can update your accounts. If you don't have simultaneous secondary billing, it's going to tell you how to secondary bill. It's going to tell you how to adjust. But basically, it's going to give you payments and other adjustments. Of course, payments are adjustments also, but to your accounting system. It's going to give you contractuals, limits, and essentially patient responsibility. Those are kind of the core elements of it. So to get into a little bit of the key components and I think nowadays with most people having Cerner, Epic, a lot of these systems, I don't always know what you're actually seeing in your system. I know what the data looks like, and I know what some of the reports look like in these systems. But just basically what these come in is I'm going to go through some of the key data elements within that 835. And you may recognize some of these in your reporting system. And in fact, if you look at EOBs, even the patient EOBs, the explanations of benefits that come directly to the patients, you will quite often note that even the EOBs will use some of these numbers and just like they will use some numbers like for your CPTs and HCPCS, or even something that almost looks like your charge descriptions. So we have, out of there, we have the claim payment information, CLP, and basically the first one is just the identifier of what this claim is. And that generally comes from your accounting system. And I'm going to bring this up a few times. I think one of the biggest misunderstandings that providers have about the 835 remit is it is not an echo of the 837. It uses your information differently, and it does not give it back to you as an echo to what you send to the payer. And we'll talk a little bit about that. But quite often that identifier is some combination of your claim number, and maybe like a claim number and a Julian date is quite often how that comes out. It is not, if you think of it, which could be a patient count number. It just depends on how your system works. But it is definitely not an MRN because it's unique to this encounter. I'm sure there's an exception to that, but I'm sure somebody will come up with an exception to that, but I'd say that's generally true. The state claim status code, these are pretty straightforward. For those of you who work in accounts receivable, you'll know that the one we hate to see is the 22, which is what we quite often call the take back, which is your reversal. And later on, I'll show you some examples of this. But essentially, you can see 1, it's processed as primary, secondary, tertiary. 4, that's where it's actually, and you won't actually see this as much as you think. I'm going to show you and talk about lots of examples of when claims are denied, but they do not have a status code of 4. I swear, I think some payers don't even use this claim status code. And then CLP 3 is the total charge on the claim. And then you're going to then, CLP 04 and CLP 05 are your combinations of essentially what the payer is valuing the claim at. So of course, depending upon the benefit of the patient, where they are in the deductible, et cetera, what's covered, what's not covered, it's going to adjust the patient responsibility versus the payer amount. So the payer amount, and again, if you think of the 835 as a long string of accounting transactions, that CLP 04 is going to add up to essentially when you get this batch of 835s and then you're going to get an ETF for your payment, it's going to match the CLP 04 minus any of the 22s. That should balance. And generally, you'll have somebody in your accounts receivable that's looking at those numbers, balancing it out. For us old people used to sit there with a 10 key, and actually be typing this all out on the 10 key and balancing these out, taking batches of checks and paper. with a rubber band and attaching the 10-key tape at the top. I kid you not. That's people complain about the automation here, but it's really replaced all that effort. So CLP4, pay or payment. CLP05 is the patient responsibility. So that is essentially what the payer is saying, hey, provider, that's what you need to now go after the patient for. I will tell you a little trick here. When I used to do a lot of denials work, I would look for claims where CLP03, total charge, and CLP45 added up together equaled the total charge. And if you haven't figured it out that yet, if your total charge equals your total valuation of the claim, you've probably hit a lesser of. So that was always one of the easiest ways I had to identify lesser of claims, was just looking for that one for one. Maybe that was super obvious to you, but if not, there's a little tidbit of information. So let's talk a little bit about what this 835 looks like. Again, it's going into your automated accounts receivable system. You've probably never seen this. It's just a long string of asterisk, generally asterisk. It doesn't have to be required to be asterisk, but general people use asterisk delimited characters to define the loops and segments within the 835 data set. And the 835 compared to the 837 is so much simpler. As an example, I think the last time I looked at it, the implementation guide for the 835 is like 127 pages. It's about 630 or 40 pages for the 837, the claim format. So it's much simpler, much more straightforward. A lot fewer rabbit holes to go down on the 835 than the 837. But two core elements that we need to understand are remittance advice remark codes. And again, I've given you the link here for that whole list. And every time I do this presentation, I kind of update how the numbers have changed. And I think in the last few years, it's gone from 770 that when I counted them up last time, it was 1,101. And these are, and we'll get into a little explanation of what those are. And then we have claim adjustment reason codes, which you may be much more familiar with. And again, these didn't exist until we had an automated format. And certainly the remittance did. The claim, you did see some of that when people submitted their paper remits, but not the remittance advice remark codes. And again, there's a link to where those are. So the claim adjustment reason codes are to indicate why you were not billed 100, you were not paid, or the claim was not valued at 100% of your charge. And you start out with these alpha code, 2-digit alpha codes to start with on the claim adjustment reason code that tell you essentially how this all started out. So you have contractual adjustment, you have contractions and reversal, and I think I have a typo there because I think that's supposed to be 50-10. So if you have a CR, for those of you who remember back in, what was it, like 2015, we converted from a 40-10 to a 50-10 on the 837 format. If you didn't understand what I just said, that you are living a better life. But if you understood that, you remember back to that. So CR is still out there, but it's not in the current mandated transaction set. OA is other adjustment, PI payer initiated reductions, and then PR patient responsibility. So the great part about this is those all seem fairly straightforward. I guarantee you your payers use those pretty much however they want. Like, for example, you'll see PRs, you'll see COs on patient responsibility, you'll see OAs all over the place. It's just one of those things where you learn the payer, you learn how they are using these, and what it means if they change from one to the other. So it's kind of like we have a structure of language here, but it's all spoken in slightly different dialects. So here's an example of some combinations of CARCs and the codes where we have PR, which is, and it says PR 27, and that was just posted and says expenses occurred after coverage terminated, which is, again, these are common denial codes basically that come in. And then two, contractual, this is a contractual adjustment or CO here, where it's just saying that's a coinsurance amount, so it's being adjusted for that amount. Okay, remittance advice or mark codes provide additional information. And there, when you pull up the list online, what you'll see is there are different kinds. There are supplemental information, and they will give you an idea of what's going on. And for example, there are, I call them RARCs, but basically remittance advice from mark codes that will tell you that you're not being paid because you have somebody in a Affordable Care Act plan that has not paid their premiums like 1 month, 2 months, 3 months. So they're going to give you an update as to like people aren't paying their premiums, and then they'll tell you whether, and then there are RARCs that'll tell you resubmit, don't resubmit, but it just gives you additional information about what's going on with that claim, that more than what's in the CARC level information. Okay, a little bit of talking about what's not in the ANSI 835. So for example, when you send out a 837, the claim, A1 is a supplier, which is also known as a physician. So anything that's not a institutional claim, a hospital, is considered a supplier, whether that's DME, whether that's a physician, home health, any of that stuff. And so it actually indicates when you send out in the claim in the header, it says A1, and then all the institutional is A2, slightly different format. But that's not, when you send out that 835, that bit of information does not come back in your 837, which may be interesting if you have provider-based clinics, all those things, and you're trying to sort out remittances sometimes. That's not going to help you. The other thing that's not on there is whenever you send out a claim, you're going to have the NPI, which is the National Provider Indicator, right? National Provider, which is essentially telling us who the hospital is or who the physician is. And it's a great number. Like I used to have customers that I would identify, they'd say like, think about this. They'd say, well, how many oncology denials did I have? I'd say, well, on your claim for oncology, you have lab, you have imaging, you might have clinic, you might have some room charges, you might have, so you're going to have like 20 different revenue codes on this claim for an oncology visit. And I'm saying like, so when you get this remit back, who does that belong to? I mean, it belongs to all those departments. So the best way I found to divide up the remits as far as denials was actually use the NPI that goes out on the 837. So I'd say, give me all of your oncologist NPIs, and then I can bucket all of your NPI denials as an example. But I'm skipping ahead a little bit to denials. But and again, dates of services aren't on there either. Now, this is something that I've shown to people over and over again because it's almost like they don't believe me. If you go look in your billing system, your accounts receivable system, and I challenge you to go in there and count how many payer names you have, because it's very typical to have 800 to 2,000 names in there. And it makes sense because quite often each one of those payer names is tied to essentially an address. Like you might have 17 different Blue Crosses because one of them is Pipe Fitters of America's Blue Cross contract, and that's really who you're billing. They may be a TPA for the Blue Cross with that particular payer, et cetera, et cetera. I mean, you understand what I'm saying. So when you'll have all these different payer names in your system that go out, but when your payer comes back, it's not going to look like that. It's very hard to match it up by payer when you're trying to do, and a lot of this goes into your analytics. I mean, you're going to be able to find the account that goes with it, and then back in on your billing system, you would know the payer name. But just strictly looking at the 835 data, if you're trying to manage your 835 data like in a denials management approach, it's not going to be a one-for-one. And I will literally go on with customers and show them like 1,000 names over here, 42 names over on this side. So that becomes a challenge. Now, in theory, this was all addressed because there is a payer ID. There's still an index for this. You can go out and Google it and still find the link. I didn't put it out here, but you would, in a perfect world, this would all work, and you would just match it up by the payer ID that comes back on the 835, and you go, oh yeah, well that's payer, it goes there. I could, and a lot of this isn't necessarily for matching up specific payments. It's more for your analytics and trying to understand how your payers are performing from a denial standpoint. The problem is that when I look at this in data, it's I think the technical word is crap most of the time. I think that's the technical word. I think it actually is a derivative of the French term. But I will look at a system, it's supposed to be a 4-digit numeric number. And then I'll go in, and as you can see in my example, I'll start pulling up, like, there's alpha in there, it'll be 1, 2, or 3 digits, et cetera, et cetera. So you guys may have worked in a world where this works. It should work. It seems like the easiest thing that should work. But what I think happens is, and if there's anybody out here who works for one of these organizations, I apologize in advance. I think it gets overwritten in some of the clearinghouse routines. And also when you're doing bridging before you send stuff to clearinghouse, I think quite often this is what gets messed up because, and somebody did a study years ago and they were looking at how many times a commercial claim had bounced around between different clearinghouses and different little entities, even within the clearinghouse. And it's like, this is what people were trying to use to direct that data. And so quite often it would get changed, overwritten, batched differently, et cetera. But anyway, there is something out there, if we want to talk to you about going down the rabbit hole, that should have made all of this analytics much easier. But it's too bad. Okay, so keep the questions coming. But I'm going to switch on, and if that little presentation about 835 specifics, if you have further questions about that, put them in the chat room. And at the end, if you want to email me also, if you have other questions, or you think, hey, Seth, you should have discussed this or brought that up, because I always love that feedback. Always want to know what should I have talked about? Because I have an idea and I do hear from people, but I really love to know what people think is interesting to hear about or questions they have. Okay, let's talk a little bit about denial. So I did a presentation at, I think it was the Texas Regional Conference a few years ago. And I asked the group, I said, what's a denial? And some people just said, I don't know. Somebody just tells me when it's a denial. I don't know. But so years ago, I developed my definition of what a denial is. And it's receiving a payer communication that's not what you were expecting when you sent the claim. And it's not just not being paid, because we have what I call them zero pay denials. These are my terms. I'm happy for anybody to use them. They're not trademarked. Please use them. Zero pay denial. When you expect a payment and receive a remit that has a payer value of 0. So the payer has valued the claim at 0. Partial pay denial is when you receive a remit that has a value, but it's different than what you were thinking. And here I kind of filled this in for what the payer should be saying to you, saying, I know this is not what you were expecting because we have a contract, right? But I'm giving you this information so you know why it's not exactly what you're expecting. So there could be as you guys all know, there could be all kinds of different limitations as to the payment that you weren't expecting. I'm going to show you one of the classic ones here in just a second. I'm going to take some tea here real quick. Okay, so depending on how your system is set up, you may identify denials not by doing the financial balancing like I was talking about, but you may be looking at that status code. Remember, I know it seems like an eternity ago, but like maybe 15, 20 minutes ago when I was talking about the status codes. And if you remember, 4 was a denial and 22 was essentially a take back, right? So you could identify it by status code, or you could identify it by that claim adjustment reason code. Now, if I remember correctly, and somebody, I'll say this with somewhat confidence, I believe out of those 700 and something claim adjustment reason codes, there's only one that actually has the word denial in it. But you're going to see some that like are CARC 18, which is duplicate claim or service, 16 missing information, 252 missing attachment. I will tell you my favorite claim adjustment reason code and why you shouldn't be getting paid on this one. Again, you could identify denial. I think it's CARC 13 is services provided after the patient's expired. So that's a pretty easy one. If the patient's expired and you send out a claim for a service date after the patient's expired, you're unlikely to be paid for that service. Again, as I've told people over the years, that's probably the easiest denial to fix because you probably have a service date error, I would assume. Unless you're actually resurrecting patients on your facility, that's the most likely explanation. But again, both of those codes come from the remits. They're going into your systems. And again, you want to understand how to use those and how to adjust them. I will tell you that the claim adjustment reason code can be very misleading, and we'll talk a little bit about that. Again, zero pay denial, where the zero payer payment, which is the CLP04, and the patient responsibility of zero CLP05. And I talk about this claim group when the balance of the claim group nets to 0. And what that means is, and you'll see this over and over again, I have seen where you have a remit that comes in and it has a value, and then either in the same batch or in the batch the next week, it has a 22 with a negative number and brings it right back out. So what I call these claim groups is, if you go back to the original remit, and let me, hold on one second, let me see if I can explain this. I thought I had a picture of this, but I don't think I do. But on the claim group, what happens is you send out a claim, you get a remit. You send out another claim, and you go back and forth. And I actually have a system for tracking the number of remits associated with one claim. And again, there's multiple claims, but that one initial claim. So in 837 speak, you send out a 131, which is an initial outpatient claim. And then maybe you send out a 135, which is late charges, or 137, which adds, which is a replacement claim to your original 131, or 131 and a 135. So you send out all these claims. When you send out that first claim, what happens is the payer sends you back a remit, and they have generally it's called a DCN, and I think it's in CLP07, but it's a payer control number. And what you're doing with the payers and the providers is you're playing this game of using these control numbers to make sure you get back to the original claim. For example, if you send out a 137, which is a revised claim essentially, after you send out the 131 and you don't include that payer control number, that DCN, in your 837, the payer is going to deny it as a duplicate claim or service. They're not even going to read it. And I worked with a customer years ago that had this horrendous denial rate, and they literally were just not ever incorporating the payer control number. So they had this rate of this particular claim adjustment reason code 18 for duplicate claim or service that was off the charts. And I said, well, that's an easy fix. You guys just don't know how to bill a 137. So those claim groups become like a big family, and you gotta identify them, you gotta keep them together, and financially you have to be able to balance them, because I think I've got some examples coming up where we show you like it's this game of payment take back, and you just have to be able to keep track of them and not waste a lot of time trying to understand what's going on. Okay, um, there are other examples, but I'll give you probably the most common example. So for disproportionate share hospital payments, we have to make sure that we are sending a claim to Medicare, even when it is a Medicare Advantage patient that's an inpatient. And that we make, excuse me, and the reason is because we want to make sure we get an accurate count for our dish calculations. So they are only informational claims only. They're just to record Medicare days. Now, there are a whole host of ways to identify them. The standard by the book is really easy. Use a bill type of 110, not 111, but 110. Send them your claim. It has all your information that you're sending to the Advantage plan, and it allows Medicare to easily, I say easily, I don't know if it's easy, but allows them to keep track of the days. Now, when you send out the bill type 110, and again, there are some other ways to do this. You're not expecting a payment. So when it comes back, you'll get a remit back, and it can say denied or other things. But anyway, these are some of the other methods or responses to the, you can get a CART 22, you can get a RARC in 211. Essentially, these are just different ways you get responses that say you're not getting paid for this. This is not a big problem like it used to be, but it used to be a bigger problem when we had the sequestration, and we get all these, especially managed Medicare ones, that would take the adjustment, which they weren't even really supposed to take the adjustment. Medicaid, again, this is more of a state-by-state thing, but what we see is a lot of 45s, which is fee schedule adjustment. And we will see denials, essentially where you get paid nothing. You get a 0 in the CLP04 and a 0 in CLP05. And the only CARC on there will be, you'll get a state claim status code of 2, which means secondary, but you'll get a 2 for fee schedule adjustment, which makes sense if Medicaid was secondary, but I've seen this in a lot of primary accounts. So again, that goes back to understanding how the claim status codes work and how they should work in conjunction with the claim adjustment reason codes. Okay, a little discussion about working denials. And again, and I know we're talking about 835s, but it kind of just all rolls together. First, so you get all your remits, they come in. Generally, your system will divide them up by CARCs. Here's the interesting thing about that is quite often you'll get multiple CARCs on the same claim. You get one's related to payment, one's related to coverage, et cetera. So how do you work them? If you're dividing them up by CARCs, do you have a method for that? And then they go to generally a work queue for somebody to work, hopefully. So the big question is, do you work denials or do you work issues? Because it seems to be the more productive ways to try to figure out what the issues are. Do you have a payer-specific issue where you're not understanding either what the coverage limitations are or they want it billed a certain way? And I'll give you a great example. There is a CARC for 16, which is missing information. I think I mentioned this earlier. And there's a CARC 252 for missing attachment. Payers use those differently. They may mean the same thing. The missing information that you didn't provide may be an attachment. And 10 years ago, almost now, when we came out with the 837-5010, we can put, I think, up to 130 images or something of attachments in there to try to forestall this. So if you know, and you guys that work this know this, but if you know the payer is going to need an op report, then you can actually attach that to the claim. What they don't want you to do is attach the entire medical record. But again, if you had an issue where now you're getting all those 252s and you can figure out, oh, if I have a surgical revenue code 360, I know they're going to an op report. I need to create a workflow that every time for this particular payer, I get an attachment for that claim of the op report before I send out the bill, and I got a bill hold, until essentially that transcription, dictation, transcription, op report, whatever is done, and then I can get that on the claim. Then I avoid all those 252s or those 16s. As an example, that's an issue. So you need to have a good analytical method for spotting payer behavior to try to prevent those denials. And again, there's going to be all kinds of discussion about denials as to, which ones are fatal, which ones should I be working, which ones can I avoid. Certainly avoidance is the best way but to avoid, you have to understand, in my view. So this is just an example of, let's see, we've got, so I pulled this one up, and this one has, I don't know, like 4 or 5 different remit dates here. It goes, and this is an old one. This tells you how long I've been doing this now, but it hasn't changed. So you got like December 2013, then April, then July, and then what is this? September, December to September, all the way. And essentially it's, you get nothing denied the first 2, 4. Then you get a primary payment. You get a charge of $552 and a primary payment for Medicaid of $52.99. Then you get it denied on the same one, and it take back 2 months later, or a month and a half later, or whatever it is, how many days that is. So again, this is why we talk about the claim group. That all goes back to one claim number, but it's all the same activity. So, and again, this is just looking at, again, trying to understand this data. CARC 45 here is a contractual adjustment. And there's 18, duplicate claim. There's your RARC reference, duplicate claim or service, etc. So again, just talking a little bit about what people do that are successful. This is, they work specific denials. So if you have not necessarily avoidable denials, you're trying to filter out denials that, as I say, are unproductive. If you can work in batch, one of the things I found is, especially when you have a change in payer behavior, new payers, change in procedure, if you can batch them up and get a settlement and be able to post that instead of having to go through them, do them one by one, that's always, in the rare times you can do that. Doesn't happen often, but whenever it comes up, you should take advantage of it. Other than working them, I try to work them by priority, by success rate, essentially by return. Where would you spend your money? Just think of it that way. Give you just a little example. This is an easy example. This is an example of a HCPCS change. So Medicare changes to out of the CPT level 1 to CPT level 2 for the office visits. And they just said, we're going to have our own code, right? Well, what happened over a number of years is some payers have adopted that and some haven't. So that was like a very avoidable denial once you detected it. Once you figured out that, oh, now this payer likes this code. They don't want to deal with the different levels. They just want this one code. But again, it's a detection. It's an easy one to fix once you figure out what's going on. And again, here's an example of that. And you get a RARC, and I pulled up the RARC here, basically says that service is not in our fee schedule. So you build a G0463, they were looking for a 99201 to a 99215. But that's one where you can kind of look at this and go, okay, I can guess, I can figure it out. I can see how many of these I have. Maybe if I got 1,000 of them with this one payer, I can batch them up and say, hey, let's settle this out. And then we'll bill you the CPT level from now on. It's just an example. The other way to look at denials, again, I'm giving you different ways to slice them. You can also look at them as administrative or clinical. And to me, that's about who's got to work them. For example, eligibility is going to be always an administrative issue, right? Trying to figure out what the right CPT code is or the dates of service or something. Somebody clinical may have to look at that as an example. So we try to always divide that up by work assignment, give it to a group that makes the most sense. And at the highest level, we're counting them by administrative versus clinical. People have other ways. People will count them like fatal, non-fatal. In other words, which are ones it doesn't matter. I'm never going to get paid for this, so I'm not going to work it, etc. So I tend to look at it as, I do it this way: denial class, and then I go to reason category, which are bundles of cards to me. So I take all the eligibility ones together, like the COB ones, the data service after coverage, all of those are generally worked by one group. They're in there looking at the insurance information and trying to figure out, did we bill the right people? Did we bill in the right order? Is this a date where we should have gone to another payer? Did we miss another payer? Did we attach the wrong insurance to this account? You got it, right? And then coding are the ones that, like, should I bill the G0463 or the 99213? And then you have the other ones where, they're just billing, and that may be an example also. I'll dig a little deeper. But those may be the people that are saying Aetna, surgical, have to have an op report. They may be the ones. I mean, that doesn't require any clinical information. That doesn't, that's, so you may break those up. And then those may be groups of claim adjustment reason codes that go up into those categories. So, for example, duplicate services quite often, not always, but I generally would start that with my billing group, because I'm just trying to figure out if I don't have my claim groups grouped together right, et cetera. Missing info may also be a billing one. Covered by another payer, 22, which is a COB issue, may be an eligibility question. Somebody's going to have to dig into the insurance. So I tend to stack these: hierarchy, priority, look at the success rating, other factors, and again, working issues versus individual remits. And those are some of my examples of work groups: coding, case management, registration, billing, etc. Because case management may be dealing with all your inpatients before you even discharge them. And again, this what we talked about earlier, which was you may have multiple reasons for denials, and you have to figure out how you're going to stack those up. And again, how do you measure success? Metrics. When do you win? When do you not win? What are your successful issues? Where you're unsuccessful? I call them wins. I feel like it's pretty straightforward. And then I look at stats on this. Recovery. Generally, when I look at recovery, it depends on the state. It really does. It's crazy how it's a state by state thing. But I look at data sometimes where the recovery rate on what looks like a denial you could recover from will be as low as 5%. And I think the highest I've ever seen is in the 20% rate. So people are still, I think, leaving a lot of opportunity on the denials. And then I have deep thoughts for you. I know all you Saturday Night Live fans love deep thoughts. But again, total recovery is down is good if your denial rate is also down. And look at your average recovery versus your recovery rates. Those are all important things to track. That is all I have. You heard 45 minutes straight of me talking. So Kelly, I think if we have questions, this would be a great time for questions.
Yeah, absolutely, Seth. I did just drop it in the chat, so we'll see as a reminder here if anybody does have questions they want to have answered live. I did see a comment. Let me scroll back up, though, to where I saw Angie Ray did advise regarding data service not being on 835s. In the 2110 segment, we see service line as well as DTM, or dates of service billed for the service. So
yeah,
we did have
so
that comment.
That's, as I remember, that's BTR 16, which is actually the date of the remit or the date of the claim. There's two different, there's BTR 16, there's BTO4, which one of them is from the 837, and I believe BTR 16 is from the remit. And it's not actually, this has been my experience, it's not actually the date of service. It's, I believe, the date of the remit from the header, or it matches up to the BT04 from the claim. But
Thanks.
I like the fact that you're reading those in great detail.
And we do have a question from Kat, I think partially for you, Seth, and also maybe a bit for the audience as well. The question is, has anyone had any success in leveraging the contracting process to standardize a payer's 835 remittance data?
That's a great question. In theory, they're already standardized. They're standard data sets. It's how people are actually using them that aren't standard. And some of them conform to legacy payment systems for the payers, and some of them are. So I've been looking at this data since it first came out. And what I found is whenever we develop software for this data, we have to put in 1,000 fixes because the providers are not even completing all the required fields on an 837 typically. Now, I'm sure they've gotten much better at it over and over and every year. But there already are standard, these are standard data sets. It's really how people apply them. And, you know, you would, I mean, even with Medicare, you have all these different MACs and they have the exact same software. Well, yeah, they should have all the same FIS and all that, but they still are somewhat inconsistent. You have all these different Medicaid systems. They're all different. California even uses their own codes. We all know, right? You have your Z and your X's codes. So you don't even use the same codes. But I would say they are standardized, but I think there is always an effort to standardize the practice, but the data sets are already standard. And if anyone else has a thought on that, love to hear it.
Yeah. Kristen did add some feedback there in the chat as well. So appreciate you chiming in, Kristen. We did have another question come in, Seth, and that is, are there any indicators in the 835 that could be leveraged when the zero pay denial is the result of a recoupment?
When the what is recoupment?
When the zero pay denial is the result of a recoupment.
Well, the 22 will tell you that. So the status code 22 should match to essentially a credit on the or a debit on the AR system for the recoupment. So if you look at your 22s, those should all be recoupments. I don't know if that answered that question.
Let me keep an eye on the chat. What segment is the status code 22 reflected in?
I think it's CLPO. Man, now I have to go look at my own presentation. Status code is CLPO2, right? CLPO1 is identifier. 2 is status code. 3 is charges. 4 is payer payment. 5 is patient responsibility. Yeah. Okay. 2. Man, it's like a pop quiz now.
I know. I was going to give you brownie points, Kat, for stumping the presenter.
Well, I'm sure that's not that hard.
I'll keep an eye out for a couple other questions here, but did just want to provide some housekeeping reminders for the larger group. We still have over 50 folks on. So again, thank you so much for joining us today. I did put in the link above. So before we close out today, I want to make sure if you are interested in the regional education, hearing subject matter experts like Seth and others, please go grab that Region 10 calendar so you can save that as a favorite. Region 10 does strive to give not only certification boot camps, but also just ongoing lunch and learn sessions, very much like this one, so that you can have that education at your fingertips. Seth's email is on the screen here. So again, would love the feedback on today's presentation, what you'd like to hear more of, and how we as an Arizona chapter and as a region can continue to provide value for you. We will be providing some information to you all regarding today's presentation. So we'll need a couple days to get that out to the distribution group, but you will get a copy of those slides so that you have them available for reference. And Seth, I don't see any other questions coming in. Any other closing thoughts you want to offer with the group?
All I'd ask is if you guys have feedback on, again, what I should have covered, should leave off, other topics, happy to present on those. On the payer contracting side, I do a presentation on managing lesser of. And of course, if that's ever of interest, people let me know, and I'm happy to do that for groups also. Thank you.
Perfect. Well, Seth, thank you so much. Everybody have a wonderful rest of your week, and we will get the slides out to you here within the next couple of days. We'll see you soon.
Thank you.